Oh, it's all yours.
All right, thank you. Good morning, everyone. I'm Camden Doran. I'm the supervisor with the Northern Virginia Long-Term Care Ombudsman Program. A little bit about me quickly. I've been working as a Fairfax County employee since 2006. I started in their adult services program, and then in 2017, I moved over to the Ombudsman program. My background is largely in social work. I have my bachelor's in social work, my master's in human services administration. I'm also a certified volunteer administrator. And I'm really excited today to tell you all about our awesome Northern Virginia Long-Term Care Ombudsman program. So can everyone hear me okay? I did bring a microphone. I wasn't sure which option would be clearer for you. Am I clear?
I can hear you just fine.
Okay, good. All right. I'm going to go ahead and share my screen. Okay. Um, all right, I'm gonna go to, can everyone see my screen?
Yes.
Okay, great. All right, and you're getting the large slide, not the abbreviated version that I'm getting, correct?
Well, no, we're getting the smaller one with the next slide
Hmm,
being displayed.
how do I get you onto the other one, I
Well,
wonder?
look at the maybe the display settings at the top there.
You can tell how often I use Zoom. I'm more of a Teams gal. Let's see.
Yeah, right above your cursor, I see display settings. Is that
Right above my cursor. Sorry, guys, I don't see display settings. I'm blind, sorry.
On the top of your screen above the main slide, the Northern Virginia Long-Term Care, it's the second one in the in. Says display settings.
Okay, sorry guys. I don't see display settings.
It's not that distracting. You could go from here.
Okay, I will. Sorry guys, I don't see display settings on my, you may see it, but I don't see it. Okay, we're just gonna actually, sorry, I'm gonna stop sharing and try this again. Um, how about that?
perfect?
Okay, wonderful. All right, well, so let's start over. I'm Camden Doran, supervisor of the Northern Virginia Long-Term Care Ombudsman Program. So we will go to the next slide. What is a long-term care ombudsman? So this is sort of just a generic definition about who we are. We are a resident-directed representative who advocates for the highest quality of life and care for people receiving long-term care services. So we are a federally mandated program under the Older Americans Act, and that act does require every state to have an ombudsman program. You'll see that the term resident directed is highlighted there, and that is on purpose because that is really sort of a sacrosanct tenet of our program. We do not do anything without direction from the long-term care resident or consumer. They must give us permission before we can provide our services. And the reason that is the case for our program is because there are very strict disclosure limitations within the Older Americans Act. And Congress has indicated that its intent for our program is to be a safe, person-centered place for residents to bring their concerns. We are designed to represent the interest of the resident in order to support them to make their own informed decisions about the disclosure of their information. So we always have to have their permission first. If they are unable to give us permission, if they have someone who's been designated to make decisions on their behalf, then that person would give us their permission instead. So most ombudsman offices across the state, and we have 19 of those in Virginia, staffed by 33 local ombudsmen. Most of those 33 local ombudsmen do work part-time. Either they work less than 40 hours a week, or perhaps they split their role. Maybe they do ombudsman half of the week, and then they do another program like VICAP, which is the insurance counseling program offered through the state of Virginia around Medicare benefits. We also have 6 managed care advocates who can assist those that are receiving Medicaid services, and they're located throughout the state. They're not all in one office. Throughout the Commonwealth, we have approximately 1,000 facilities with over 70,000 residents living in those facilities. Virginia operates in what we call a decentralized structure. So we have a state office that's located in Richmond, and then you have the 19 local offices sort of scattered throughout the state. And all of those local ombudsmen that are in those offices are called representatives of the state office. And what happens is the state ombudsman office creates memorandums of understandings with all of these different host agencies that host these 19 offices. And then, within those MOUs, they determine like what are the conflicts of interest, how can we remedy, and then we just sort of talk about how we do our work as opposed to the host agency. So our office is located in the Fairfax County Area Agency on Aging, and we cover the following jurisdictions: the cities of Alexandria, Fairfax, and Falls Church, and the counties of Arlington, Fairfax, and Loudoun. We have 7 full-time staff ombudsmen, and we currently have 25 volunteers. I will say that these numbers, in terms of the volunteers, that's a fluid number. Sometimes we have more, sometimes we have less. But for right now, we have 25. The way it works in terms of us being housed in Fairfax County and they are our host agency, they are in charge of our personnel policies and procedures. We are technically Fairfax County employees, but when it comes to the programmatic policies and procedures, that is dictated by the state. And so our host agency cannot interfere with the state's oversight of our program. So some of the ways that we try to prevent that interference from occurring is we have our own separate intake line, we have our own separate database. We cannot openly discuss our cases with other Fairfax County employees, but that also extends to employees of the other jurisdictions that we serve. Without residents' permission. And then the final decision about whether or not we get involved with a resident lies solely with the ombudsman program. Currently within the jurisdictions that we serve, we have 151 long-term care facilities. That's a combination of both assisted and nursing facilities. Within those facilities, we have 12,933 licensed beds. Also within the state of Virginia, we have discretion to get involved with long-term care consumers in the community that may be receiving community-based long-term care services, and that would be home health, hospice, or adult day health care. I will say 99.5% of our work is usually located within a facility, but occasionally we will get calls and requests to get involved from those folks out in the community. So this is sort of a brief rundown of all the things that we do. I could keep you here all day if I really wanted to go through every single thing we do. We're a very nuanced program, but I value your time too much to do that. So I'll try to get through this pretty quickly. The main thing that we do is to resolve complaints made by or for residents, consumers of long-term care facilities and services. So when we are helping someone resolve complaints, there's 2 ways that we can advocate depending on the nature of the complaint. We can open an individual case with an individual resident and address whatever concerns they may have at that time. Or we can do a systemic case, which may involve multiple residents. So sometimes a resident also might want to be anonymous when working with us. We can attempt to advocate for a resident in that way, but sometimes it does make it a little difficult and it might limit the work we can do, because if they are coming to us with a very specific complaint specific to them, remaining anonymous might limit how we can advocate for that person. Our cases are meant to be short-term and to address acute issues. We do not keep cases open ongoing. We do not provide case management services. Our staff, we are not intended to be substitutes for caregivers, facility staff, Medicaid eligibility workers, or social workers. There are folks within these facilities that can help with those roles. So our job would mainly be able to, or try to connect the resident with the person that can help them with that particular issue. We can get involved in cases of abuse, neglect, or exploitation, but we don't get involved in the same way as Adult Protective Services or licensing. We are not an official substantiator on behalf of the state or another government entity. So those substantiation determinations are always made by either Adult Protective Services staff or a regulatory agency. Instead, again, as we're resident directed, we represent the residents' interests rather than the states or government. So we're not going to go in there to officially determine whether a law or a regulation has been violated. We investigate solely for the purpose of gathering necessary information to resolve the complaint to the resident's satisfaction. And for any type of case that we get involved with, the resolution in terms of, was this complaint resolved, partially resolved, not resolved at all, that's always determined by the resident. It's not determined by us. So it's a very subjective measure for our program, and we usually don't use it as a formal measure when we're creating reports, because we could have done everything under the sun to advocate for that resident. The facility staff may have provided all that they needed and then some, but if at the end of the day the resident decides that it has not been resolved, sometimes that's how we have to close the case, because that's the resident determines that resolution piece. We also educate about residents' rights and long-term care issues. Much like today, we do a lot of community outreach. That's how we spread the word about our awesome program. We also promote community involvement through our volunteer program and support for the development of family and resident councils. So our volunteer program is near and dear to my heart. Before I transitioned to supervisor, I was the volunteer coordinator for this program for 5 years. They are amazing individuals. We have a program in which we recruit, retrain, and we place all of our volunteers. They primarily serve in long-term care facilities. They do not get involved in the community-based long-term care cases that we may get from time to time. Both the vols and the staff have to go through a very comprehensive initial training program, and we're all required to continue to receive ongoing training throughout the year to maintain our certification. We also have very strict conflict of interest requirements that we all have to meet before we can be a part of the program. We also help support the foundation of resident and family councils by providing information and technical assistance on how to get them up and running. And we also work to ensure that facilities are supporting the formation of these councils as well. We can attend those council meetings, but we can only attend upon invitation or with an invitation from either the resident or a resident or the families. And we attend mostly as observers. If we're requested by the council members, we can share information about our program at a meeting or provide input on a topic that may be discussed. And then our last bullet talks about how we provide access to residents, families, and provider staff through, we have an intake line, we do on-site visits to our facilities, and then weekly visits by our trained volunteers. So we provide quarterly visits to our facilities, and we have an intake line that is staffed by Ombudsman every day during business hours, Monday through Friday. And a big part of our work actually is just providing information and assistance to folks that give us a call or folks that we may run into in the facility. So just to give you kind of a brief statistic, last program year, we provided over 12,000 information and assistance requests, either through our intake line and our group email. So this is a very brief list of residents' rights, which is also the crux of our program. There is a comprehensive version of these in both the regulations for assisted living and nursing. I just wanted to highlight a couple of them to discuss today. Firstly, being informed of your rights. I think a lot of people think when they move into a facility that they lose rights, but actually they gain rights. So we want to make sure that they know that and they know what their rights are. It's important for them to know what those are when they first move in. And usually that's typically, not all the time, but typically a part of their admission packet when they move into a facility. But again, as we're introducing ourselves, we just want to make sure that they're aware of what those might be. Voicing grievances is the next one that I have highlighted. It's important to us and for the residents for them to know what is their specific facility's grievance policy, because we're not in the facilities 24/7, and we don't want them to wait until the next time an ombudsman can be there to voice a grievance. So we want them to know, where can they go? Who can they talk to in the event they have a concern, and they can get it addressed in a timely manner. And then the last bullet here, access to visitors. That includes family members, friends, our program, Adult Protective Services, any other regulatory and advocacy program. This was really a big issue during COVID, many years ago. Some of you may know that the facilities were provided with guidance and they shut their doors for about 13 months. So we were not in the facilities at that time, and a lot of other agencies, and we all know family and friends were not in at that time, but it is a resident right for them to have access to visitors of their choosing. And if it's going to be an issue in terms of when they meet or how they meet, like for example, we have some residents whose family members like to visit really late at night. And if they have a roommate, that can obviously be disruptive. So how do we advocate for a situation like that? Because we want to make sure if we're advocating for that resident to receive their visitors, we're not adversely affecting the other resident, because we work for all of the residents in that facility. So we might work with that resident and their family in the facility for them to find maybe another private place within the facility for them to meet at that late hour, which allows their roommate to get the rest and not be as disrupted by the visitation. So this is just a slide that lists some of the common concerns that we come across when we're making our visits or if people are giving us a call. As you can imagine, care issues is always number one. There's some examples listed here on what a care issue might involve. Requests for assistance, call lights, that's, I would say, next to discharge, probably our number one concern that we get, call bell response. Grooming and hygiene, medication management, no notice to others, either the family or the doctor. Environmental, safety, odors, cleanliness, pest control. We get a lot of calls about pest control. And then autonomy, choice, exercise of rights and privacy. This is where we want to make sure that the residents' rights are being respected, that they're being treated with dignity and respect. Staff attitudes fall under this, choice of their plan of care, because all of the residents should be involved in planning their care. Their preferences should be honored as much as possible. And then activities also falls under here. What activities are being offered? What is the resident interested in? How can we get them engaged, if that's what they want? Dietary, food, always an issue. And I'll be honest, it's either one end of the spectrum or the other. People either love the food or they don't. I've never found someone that's just like the food in the middle. So we do get a lot of calls about food quality, or maybe a particular resident has a favorite snack that's never been offered in that facility, and they're trying to figure out how they can make that request, things like that. We also have a lot of residents that may be on a special diet, whether it's soft foods, pureed, and sometimes those diets aren't being care planned or delivered adequately, so we might get involved at that point. Access to information. Every resident has the right to access anything in their record. And it's also in the regulations that their legal representatives, whether it's a POA or someone else that they've designated to make decisions on their behalf, also has the right to access those records. And we run across this a lot, where there's a delay in getting that information to them by the facility. So we will get involved if that's the case. And that also relates to their medical information. And then we talked about visitors, including licensing or our program. And then staffing. Poor staffing levels. This, obviously, we've seen an uptick of this since COVID. I think that really exacerbated this issue, but I'll be honest, it was an issue even before COVID. These facilities have never really been adequately staffed. There isn't much that we can do in terms of personnel management within these facilities. That is not our role. So how we try to address the staffing issue is if people are coming to us with complaints, and it lends itself to the fact that maybe this is happening because you don't have enough staff, that's how we'll address it. We'll try to frame it in a way of, hey, if you had more staff, their care wouldn't be affected in this way. And so this is a true or false. And so this does sort of include some audience participation. Gary, I don't know if we want to just have people put yes or no in the chat. I can't see
Yeah,
the chat, so I might rely on you to let me know
okay.
what people are saying. So we'll just start with number one. Are ombudsmen mandated to report abuse, neglect, and exploitation to adult protective services?
Okay, so I'm seeing yes, true, yes, yes. So sounds like the answer is overwhelmingly yes.
Trick question. No, we are not. And I will say that's probably one of the most controversial policies around our program, but I'm going to explain it to you the best way I can, and hopefully it'll make sense. So no, both the Older Americans Act and the federal rule of our program prohibit us to report any resident identifying information, again, without their permission. This goes back to that resident direction piece. So by logical extension, that includes reporting abuse, neglect, or exploitation to adult protective services without consent of the resident. And that federal rule trumps any state law that would mandate me as a social worker to report to APS. And this is really only as long as I'm acting in an ombudsman capacity. If I were in that facility for any other reason, then I would be mandated to report if I had a suspicion of, or if I witnessed it, or if someone told me, hey, I think I'm being abused or neglected because of A, B, and C. But again, we go back to that resident direction. A lot of residents are afraid to have us either help them go to staff and tell them what's happening, or call APS themselves, or have us call APS or tell someone on staff. The fear of retaliation is a big thing in these facilities. Retaliation is illegal, and we have conversations about it all the time with residents, families, and staff, but it is a legitimate fear. So there are times when we have these conversations with residents and they're just not ready. So we don't just leave them high and dry. We're not like, well, great, let us know how that turns out for you. We understand the importance of that information. We want to be able to get that information to the right people so it can be looked into. So we will continue to work with that resident. We will have the conversations about why it's important to report, because what if it's not just happening to that resident? What if it's happening to other residents within the facility? By reporting, we're not just helping that resident, but we're helping a larger group of residents. So it has a bigger impact. If they give us permission to report, we can call APS ourselves. We can let someone on staff know. Everyone that works in a facility, from housekeeping to administrator, is a mandated reporter. So as soon as they get wind of potential abuse, neglect, or exploitation happening, they have timelines in which they have to report to APS, and they also have to report to their respective licensing entities. I will say more often than not, we get permission to report. If someone's bringing us in, they want their situation resolved. So they're going to be willing to let us, or perhaps have us go with them to have that conversation with someone on staff. It's very rare that someone tells us no, but it can happen. And if it does, we cannot report to APS. Moving on, in Virginia, is there a required staff to resident ratio in all long-term care facilities?
I see a yes, a no, a no, a no. So it sounds like the no's have it.
Okay, well, it's both. Another trick question. So currently, right now, the only staff to resident ratio that exists is in a memory care section of an assisted living. That ratio is 1 staff to every 10 residents. There is no staff ratio for the other parts of an assisted living, for the regular part. It's just in memory care. However, assisted living facilities have to create what they call a disclosure statement. And this is included in all of their admission packets, and it also has to be approved by licensing. And within that disclosure statement, they have to create what they call a staffing plan. So when licensing goes in to do their inspections, they're going to look at that disclosure statement and the staffing plan, and they're going to see, all right, your staffing plan says XYZ. Who do you have on the floor today? Who do you have in the building? If it doesn't match, they're going to cite that facility. And that disclosure statement is available to the public. Anybody can ask to see that if they go to a facility. It's not private information. In nursing, starting, I guess, as of yesterday, they must provide 3.08 hours of case mix adjusted total nurse staffing for each resident every day. So it's not necessarily a staff ratio like the 1 to 10 you're going to see in the memory care and assisted. It's more of an hourly model, but in order to meet that, they have to hire more staff. But there is no hard and fast, like you must have X amount of staff per residence as a part of that law. And that just went into effect yesterday. But as a result of that, nursing facilities have had to hire more staff to meet that hourly model. So the next one, most residents living in nursing facilities have long-term care Medicaid.
So I see no and false and yes. No. Yes. No. So it
Okay.
sounds like we're pretty well split.
So pretty well split. So I think this one is a depends. I will state that Medicaid is the #1 payer source for long-term care in the United States. So a majority of the people in nursing facilities are relying on long-term care Medicaid to pay for their stay. Now, it will also depend on the facility you go to. We have several facilities in our area that do not accept Medicaid. So everyone in their building is either private pay, or maybe they have long-term care insurance, or maybe their families are paying their bill. There's lots of different payer sources, but right now Medicaid is the #1 payer source for long-term care in our country. Next, assisted living and nursing facility residents will see physicians regularly.
So we're seeing no, 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 yes, yes.
Okay. So we consider the answer to this question false because define regularly. So I'll tell you what is expected in each type of setting, assisted in nursing. And I'll start with nursing. So each resident in a nursing facility must be seen by a physician within the first 30 days of their admission. And then at least once every 30 days for the first 90 days of their admission. And then after that, at least once every 60 days. So that initial comprehensive visit must be done by a physician, but all of those subsequent visits can be done by a nurse practitioner if that facility allows nurse practitioners to come into their building. I would say we see nurse practitioners a lot. And we hear that that's primarily who the residents are seeing rather than a physician most of the time. In an assisted living setting, it's a little different. Doctors don't make regular visits to assisted living facilities. I have seen nurse practitioners make visits to assisted living facilities. ALF residents typically are coordinating sort of their own transportation to get to their medical appointments outside of the facility, either with family or staff assistance, because the state does not see assisted living as a medical facility. They don't have that medical care model, even though we are seeing more and more folks in assisted living that are receiving medical care. But it tends to be that those residents have to go outside of the facility to get their medical care as opposed to those in a nursing facility. Next, facilities will provide one-on-one care if needed.
Okay, seeing no, yes, false, no, no. So it looks like
False.
yeah, yes for an additional charge.
Yes. So yes, typically facilities are not going to provide that one-on-one care. They might do it temporarily or on a limited basis following a behavioral outburst, or if you have a resident that has all of a sudden developed some additional medical issues that need a little hands-on care. But that's always going to be seen as a temporary measure, and the facilities are almost always going to come back and ask their residents or their family members to cover the one-on-one care, either paying out of pocket or using another payer source. So that could be a viable option for people who have the resources that are paying privately, but it is not a service that is covered by Medicaid. So those folks in a nursing facility that have long-term care Medicaid and are now being told by the facility, you need one-on-one care, that can be very tricky. And the families don't always have the resources to pay for that as well. And in that situation, we would advocate that since a nursing facility is the highest level of care, they should really be able to provide all the care needs for that resident. They chose to admit them, and by admitting them, they are taking on the responsibility of providing that care. But technically, the regulations don't prohibit them from asking for residents or families to cover that if requested. And in
Yeah, we've got
assisted
a
living,
comment here. We
oh
got a
yeah,
comment here from somebody who had to hire additional people when his father needed round-the-clock care.
yeah, yeah. And in assisted living, we see it a lot in assisted living, and sometimes families are willing to pay for it. Residents are, they don't want to leave. Sometimes we have to have a conversation with that resident about really, are they maybe at a higher level of care now, and assisted living setting isn't where they need to be. It's really just going to be dependent on the individual circumstances and situation. And then lastly, a resident can appeal an involuntary discharge in both an assisted living and a nursing.
I'm seeing yes, yes, no, yes, but don't get your hopes up. Yes.
Okay, so yes and no for now, but eventually yes. So true for nursing facility. Nursing facility residents have protections within their regulations and have had for some time protections around involuntary discharges. So in a nursing facility, if a resident has been there for more than 30 days, they should be receiving a 30-day discharge notice in writing. And that discharge notice should be including a reason for discharge, a place where they will be going to, the discharge date. They should also be provided with their appeal rights and the agencies that can assist them with that, including ours. There are 6 valid reasons for when a facility can initiate an involuntary discharge in nursing. It's either needs can no longer be met by the facility, non-payment, no longer meet nursing level of care, the resident's a danger to others or poses a safety risk, the health of individuals would otherwise be endangered by that resident, or the facility is closing. So those that have been in a nursing facility for less than 30 days, they are not required to receive a 30-day notice, but the facility should be giving them one as soon as possible, and it should also be in writing. But they also have all the same appeal rights as a resident who's been there for more than 30 days. We get that a lot. I think it's a common misconception that folks that have been there less than 30 days cannot appeal, but they absolutely can. In assisted living, currently, there are no formal appeal rights to a resident living within an assisted living in their regulations. The current regs state that they should begin discharge proceedings within 30 days of discharge, but they don't have to give a written notice more than 14 days in advance. However, in 2022, State Bill 40 was passed, and that will provide certain safeguards from being resident being involuntary discharged, similar to those in nursing homes. But however, as a matter of state rules and regs, those amendments have to go through a whole formal approval process, which includes the creation of the appeal process and what those protocols are going to look like, and then allowing for a public comment period before they can officially be added and adopted to the regulations. So at this time, that appeal amendments have been published. They are currently going through the public comment period until August. And then once they go through the public comment period, they'll address the comments and then they'll start the process of getting them added to the regulations and having them formally adopted. We're not expecting all of that to be formalized and finished until probably the earliest, the end of this next year, maybe in the early next year. But because this has been such a protracted process, I mean, this state bill was passed in 2022, and here we are 3 years later, and those regs don't exist. They have started taking appeals, even though the regs aren't in place. They realize we need to get this going. We get a lot of calls from people in assisted living facilities who are being discharged and want to fight back, and it's been very, very difficult because these appeal protections have not been in place. So we're very excited that they're finally now going to be put in place. And that's it for me. This is my contact information or my program's contact information. It has our mailing address. The first highlighted number you see, that's our intake line. Again, we're open Monday through Friday, 8 a.m. to 4:30. Those are our business hours. We have an ombudsman that when you call, you leave a message, they will give you a call back and talk to you about your concerns, or if you have any questions, we can help answer those. We also have a fax, and we also have an email. If email is more your thing, you're welcome to email us anytime. And then this also has our website. Our website has a lot of good information on there. So if you haven't been to our website, I would highly recommend that you check it out. So I'm going to stop sharing my screen, and I'm happy to answer any questions that you may have for me.
Okay, why don't you leave that last
Okay,
slide up?
sure.
First question, is Laura J. Nichols still in charge of the program?
Laura J. Was my supervisor when I started. No, she retired in 2022. I am now the new Laura.
Okay. Where can we find recommendations for or reviews of long-term care facilities?
So a couple different places. For nursing, the best place to go would be Nursing Home Compare through Medicare.gov, or you could just Google Nursing Home Compare and it'll take you right to that section. You can go in there and put in, I think, where you live, like different zip codes or areas, and it'll pull up the different facilities and it'll give you, there's a wealth of information on there. It also they have a 5-star rating, 1 stars to 5 stars, CMS. That's how they rate their facilities. So all of that information is there. You can also see the inspections that have been completed on that website, but you can also go to the Virginia Department of Health, the Office of Licensure and Certification, and you can find the same information there because it's actually employees from the Virginia Department of Health that go into these facilities to provide the inspections. I will say that they are behind on their inspections. They are short-staffed, much like everyone else. And so there are a lot of facilities in our area that have not had an inspection for maybe 2 to 3 years, but they have been trying to get out there as quickly as they can to get those done. For assisted living, they're licensed by the Virginia Department of Social Services. So you can go to their website and you can search for any assisted living within the Commonwealth, and you will get the name and address of the facility. You'll get the name of the executive director. You'll get the name and contact information for the person who does their inspections, and you will also be able to see their inspection reports at the same time.
Are there any important differences with what you do between regular care facilities and those that focus on cognitive decline?
If they're licensed in an assisted living or nursing facility, we are going in and we are visiting and we are providing our services to all those residents, regardless of what kind of care they're getting, regardless of their payer source. We provide the same services in terms of advocacy to all of those residents. Now, depending on the individual's needs and concerns, our advocacy will obviously look different based on what that person wants us to be involved in versus another resident.
Next question, is the Ombudsman program for long-term care facilities only, or do you also deal with developmental disability waiver issues?
We are for long-term care facilities only. So if it's licensed as an assisted living or a nursing facility, then our program goes in and we can provide our services. If it's licensed through Department of Behavioral Health as a group home, then Department of Behavioral Health would be involved in terms of providing oversight and assisting them with any advocacy that they might need. We can get involved with folks in the community that are receiving waivers at home. It used to be called the EDCD when I was in adult services. I think it's now the Commonwealth Coordinated Care Waiver. I'm not quite sure of the title, but those are for folks that meet nursing home level of care, but instead of going to a nursing home, they want to stay in their own homes in the community, and they would have an aide come to their house and provide so many hours of services. That's considered a long-term care. So under that waiver, because it's long-term care, we can get involved if there happens to be a concern about their services.
So how long-term counts as long-term care? If somebody's in rehab after surgery or an accident, Is there a, you
They're in
got to
the
be in?
facility, so we can advocate for those folks that are in the short-term rehab, just
Okay.
as we do the folks that are there for long-term. Because those folks might, even though they're there for 3-4 weeks, they might be having or experiencing some of the same issues or care concerns that the folks that are there long-term are. So we make ourselves available to those residents as well.
Okay. You already answered this one, but maybe restate it. What reasons might trigger an involuntary discharge?
Yeah, I'll go through them. Well, it depends. For nursing, right now we really only have the reasons in the regs for nursing. We're waiting to see what the regs are going to say for assisted. My understanding is they will be similar. The needs can no longer be met by the facility, so maybe someone who went in as nursing home level of care has improved and now they're no longer nursing home level of care. That would fall under needs can no longer be met by the facility. Sometimes nursing facilities will try to use this for residents that they maybe consider a little problematic or challenging. Um, if a resident wants us to get involved in that case, we would push back in terms of, well, you're a nursing home, this is the highest level of care, you're trying to transfer them or perhaps discharge them to another nursing home who is supposed to also be providing the same level of care as you. So the burden of proof is going to be on that nursing home as to why they can't provide the care, but another nursing home can. One valid reason I might see that would fall under that needs can no longer be met by the facility is if someone's in a nursing home that requires ventilator or trach care. Not all facilities provide that care, so they may try to discharge them to another facility that can provide that specific type of care. Non-payment. So if you're not paying your bills, that is a valid reason for a facility to say, hey, we've given you plenty of notice to pay your bill. You're not paying it. We're going to give you a 30-day notice. Now, if someone has run out of money and they've applied for Medicaid and that Medicaid application is pending, then they cannot be discharged while that application is pending. And that is in the regs. They have to keep them until it's determined whether or not they qualify for Medicaid. Again, no longer meet nursing facility level of care. Resident is a danger to others and poses a safety risk. The health of individuals would otherwise be endangered by the resident or the facility is closing. In my time in the Ombudsman program, we've only had one nursing home close. We haven't had any others close since I've been in the program.
Okay, next question. In a nursing facility, is staff required to get residents up and out of bed for a period every day?
I think it would depend on that person's plan of care. I will say when I visit facilities and when my staff, most people are in their rooms, in their beds. But if it is care plan for them to get in and out of their bed for a certain amount of time, or if that's the resident's preference that they don't want to be in bed all day, then the facility should be doing their darndest to make that happen. But there are some residents who are okay with being in their bed all day. So it really would depend on what the resident wants. There's nothing in the regs that says they must get every single person out of their bed for a specific amount of time.
Does your office offer advice as to what families should know and ask regarding the best nursing home for a loved one?
Yes. So I would invite anyone who is, researching a facility for either a loved one or perhaps themselves in the future. If you've narrowed it down to a few facilities, and you want some information about those specific facilities, you can give us a call. We can direct you to those locations that I mentioned earlier in terms of licensing and inspection reports. We can talk to you about, making visits, touring a facility, questions to ask during your tour. We can also provide very high level aggregate data in terms of what our program has maybe looked into in that particular facility over the past year. We're very careful about what we provide because, again, we need resident permission to provide those really nitty-gritty details. So, for example, if you were calling me about a sunrise and you wanted to know, have we been involved in any cases or problems or concerns in the past year at that facility? I would say, oh, we've had 2 or 3 cases in that facility. One was about care, one was about medication administration, one was about activities. That's the kind of information we would provide.
Okay. Do nursing homes know in advance about visits from an ombudsman or pending inspections?
No, for our program, we do not announce our visits. They would love it if we did, but we do not. Now, sometimes we do have to schedule visits with them if we're working with a resident, and now we have to sit down with the resident, family, and staff to talk about some care issues. Obviously, we're going to schedule those because we need them to be available. But otherwise, just to make our regular visits, we do not let them know when we are coming. It's supposed to be the same way with licensing, but I will tell you that um, the facilities have kind of caught on, and they kind of have over time figured out the window of when they might have an inspection due, and it might be like a 3 to 4 month time frame, because we'll hear that a lot. Oh, we're due for an inspection. They could be here anytime between February and April. And so they don't know, they don't have an exact date, but they have a general idea of when licensing might be coming.
Regarding issues that you've seen, does it make any difference whether the facility is for profit or nonprofit?
There are concerns in every type of setting, whether it's for profit or nonprofit. I will say the majority of facilities are for profit. There are very few nonprofit in our area. So I think, yeah, I mean, the concerns are the same across the board, regardless. I think they have different business models, so maybe their priorities might be a little bit different. But in terms of care, it's the same regardless.
You said you've only seen one nursing home close. Given our aging population, are you seeing a lot of new ones opening?
So we haven't seen any new nursing facilities open in a very long time. And that's largely because the nursing homes have federal oversight. They have federal regs. And so they have a lot more hoops they have to jump through and red tape that they have to go through in order to open a building. All of the new facilities that have been opening are all assisted living. It's a little easier because you have to go through the state to do that. And so those, I would say, over the past 10 to 12 years, all of our new facilities have been assisted living. When I started in the program in 2017, we had less than 120 facilities in the jurisdictions that we serve. We're now at 151. Those are all assisted.
Are you concerned about the possible Medicaid cuts that may affect older adults who otherwise can't afford long-term care?
Yes. We're not 100% sure what it's going to look like going forward. I mean, I think we've probably all seen stuff on the news, and we've seen the things on the internet about how yesterday I saw something like 1 in 4 nursing homes will close because of the Medicaid cuts. Clearly that is worrisome. I don't know about our specific area. I don't know how it will affect us here in Northern Virginia, but we are definitely sort of paying attention and needing to see how it might affect our folks.
How does a person in a rehab facility become aware of your services? They said they had a friend who could have used you guys had she known about the services you offer. How do you make yourselves known to people, to somebody that checks into rehab?
So so we visit our facilities, and we try to talk to as many residents as we can. We may not get to every single resident during our visit, but we do try to talk to as many people as we can. We leave our brochures, we talk with staff. We try to have them put our information up throughout the facility or include our information in the admissions packet. If it's a facility where we have a volunteer, our volunteers provide a more frequent presence in their facility. So they may be there every week as opposed to a staff ombudsman. For if we have a facility where we don't have a volunteer, a staff ombudsman is probably only going to be able to get there once a quarter. We have so many facilities, and we're out in Loudoun, and then we're down in South County in Arlington, and sometimes it takes us over 50 miles worth of driving just to get to a facility. And if we're spending 3 or 4 hours in a facility, it's just, as you can imagine, trying to make sure we get to all 151 facilities within every 3 months. It's quite a task.
If you ask a facility to put your stuff post it and put it in the intake package. Are they required to do that, or can they just say, "Oh, sure," and as soon as you leave, it goes in the trash?
Absolutely. No, they are not required. The only time they're required to give our information, well, there's a couple times. When discharging in a nursing facility, those involuntary discharges, they have to include our information in there, either our local office or at a minimum the state ombudsman office. In the facilities, they also have to post resident rights. It doesn't have to be a large poster in large print. It has to just be somewhere posted where people can see it. And often our information will be included there as well.
So do the ombudsman programs need more volunteers? And what kind of qualifications are you looking for in a volunteer?
Yes, all caps. We always need volunteers. Always, always, always. I mean, we have 7 staff ombudsmen and we have like 25 volunteers and we have 151 facilities. So that's just bad math. We always need more people. You don't have to have any experience in long-term care to be a volunteer ombudsman. We're looking for people who have a heart for advocacy, who want to work with older adults. They're good communicators. They're not afraid of having difficult and challenging conversations, because you will in this role. But we offer a very comprehensive new volunteer training. And so we go over probably more than that volunteer wants to know during that training to get them ready to go out into their facility. And once they're assigned to a facility, the expectation is that they will try to go every week for about 3 or 4 hours. But they can get involved and advocate for many of the same things that we can as staff. There's a couple different things that if a resident brings to the attention of the volunteer, perhaps abuse or neglect, or maybe an involuntary discharge, we would probably ask the volunteer to give our volunteer coordinator a call, and we would just have a staff ombudsman address that instead. But if you know of anyone that's interested, we'll be doing our next training in the spring.
Okay. Are all nursing and long-term care facilities in the area that you covered by your program?
Yes, if they're licensed as a nursing and assisted living facility, they're within our purview,
Okay.
within the jurisdictions that I mentioned earlier. So Arlington, Fairfax, Loudoun County, cities of Alexandria, Fairfax, and Falls Church. We used to cover Prince William, but in 2013 they branched off, so they have their own ombudsman in Prince William.
Okay, well, I think we've covered all the questions. If there are any last questions people are dying to ask, now's the time. Otherwise, it's 11 o'clock.
I'm going to stop sharing. Is that okay?
Yep.
Okay, great.
Okay, well, thank you so much. This has been really, really, really helpful, Camden. And in case people want more information, I did put the Aging Matters link. The day that I interviewed Camden, she was also joined by Amity Overall Labe, who's the director of the National Ombudsman Resource Center. So there's really lots of information that you can learn if you want to learn more, or you know somebody who wants to also learn more about the Ombudsman program. It's really, really, really an excellent program, and for people to know, both in terms of their families as well as volunteer opportunities. So Camden, thank you so much.
You're very welcome. Thank you for having me. And honestly, if you guys have more questions about our program, please do not hesitate to reach out to us, either intake line or email. We are always happy to have more conversations with folks about what we do.
Yeah, you guys are very receptive, and thank you for all of your good work.
Thank you.
Much appreciated. So next week will be about co-housing, coffee and conversation. So if you're thinking about maybe an alternative living arrangement, but not ready for assisted living, we're going to hear from Ann Zabaldo, who is the executive director of Mid-Atlantic Co-housing. So we'll learn about why you might want to consider that when thinking about future housing needs. So be sure and tune in next week at 10 o'clock. So, and until then, stay cool. Happy Independence Day to everybody. And we'll see you a week from today at 10